the new guidelines is for one of the 5 guidelines that were presented in Barcelona in the treatment of aortic disease. These are the different members of the committee. Actually, Dr. Manolis, who is here, he was one of the members of this committee. It was chaired by Raymond Herbal and Victor Aboyan. These guidelines, they focus on the different clinical conditions related with the aortic disease. I will be focusing more specifically on what I think are more relevant from a clinical standpoint, because of course the guidelines are very extensive. Actually, it's a document that I will really recommend its reading, because it contains a lot of information, not too much. I think it's very practical, but it contains important information which is quite relevant to update and to understand a little better some of the concepts related with the aortic disease. So it contains important elements regarding acute aortic syndromes, and I will be focusing most of my presentation on the acute aortic syndromes, which are really the most relevant. Also on aortic aneurysms and genetic aortic diseases, and of course then many of the other pathologies that can be observed in the aorta, and all of these are contemplated in our guidelines. Now, when we talk about, and let's focus now on acute aortic syndrome, this is a spectrum of disease that goes from intramural hematoma to the full-blown acute aortic dissection. And we can have these different entities which are included in the concept of acute aortic syndrome. So acute aortic dissection, intramural hematoma, penetrating aortic ulcer, and then some less common like aortic pseudoaneurysm, contained rupture of an aortic aneurysm, or traumatic aortic injury. And 2 important messages related to the acute aortic syndromes. One is that from a diagnostic standpoint it's challenging, and we all know in our hospitals patients who were missed and had either aortic dissection or intramural hematoma. And this is certainly one of the areas, as you will see the guidelines, try to narrow the possibility of missing these patients. And the second, which is also why it's so important to have guidelines and follow these recommendations, is that this set of diseases, if untreated, they may be rapidly deadly. And this is certainly one of the areas where to have the proper and early diagnosis is very important to establish the best therapeutic strategy for these patients. These are the 5 classes that are now considered for acute aortic syndromes. So the class 1 will be the classic aortic dissection. You have here the entry tear, and you can see the false lumen and the true lumen. Then the class 2 will be the intramural hematoma, which I will discuss a little bit later, which basically for some is sort of the first step towards aortic dissection when you have this intramural hematoma. And from a clinical standpoint, as we know and as you will see, the implications are very much the same as for acute aortic dissection. Then the class 3 will be a subtle or discrete aortic dissection with bulging of the aortic walls. It's very limited, but still relevant. The class 4 is the classical penetrating aortic ulcer, and the class 5 is when there is an iatrogenic traumatic aortic dissection, like by catheterization or any other procedure. So let's talk about the aortic dissection. As we know, there are 2 main classifications, the so-called DeBakey classification and the Stanford classification, which is probably the most used and the easiest one to use, because basically divides the patients in type A and type B, considering if there is involvement of the ACN in the aorta or not. So anytime there is involvement of the ACN in the aorta, regardless of the descending aorta also being involved, it's a type A dissection, and a type B dissection is when it is limited to the descending aorta. Then the definition of acute, subacute, and chronic So it's considered an acute aortic dissection if it occurs in less than 2 weeks, so 14 days. Subacute between 15 and 90 days, so 2 weeks and 3 months. And chronic aortic dissection if it is more than 90 days. And this is also important from a therapeutic and a management strategy. It's important to know if you have acute, subacute, or chronic dissection. So here we have another example of, and here with some numbers on the distribution of the typical aortic dissections, the type A or the type B, the most common being the type A, involving the initial portion of the ascending aorta. And this is an anatomic species of the aortic dissection with a significant amount of thrombi in the false lumen and then the true lumen. In terms of complications and the clinical presentations, we can see here a comparison between the type A and the type B. From a clinical perspective, the presentation is in both of them chest pain, which is more typical back pain in the type B, which makes sense because it involves the descending aorta. The abruptness is similar both in type A and type B, and the migrating pain is a little bit more prevalent in type B, but can also be observed in both. Of course, the presence of aortic regurgitation is it occurs in the type A because it involves the ascending aorta and can distort the aortic annulus and push or retract some of the cusps, and that's the reason, the mechanism why these patients may develop aortic regurgitation. Also, the development of cardiac tamponade, usually secondary to rupture, it's more common in patients with type A, as well as myocardial ischemia or infarction, because many times it can involve the osteo of the coronaries, particularly the right coronary, and can also be, and that's one of the reasons why, additional reason why the patients may have chest pain on top of the dissection. Then other symptoms like syncope, particularly when it involves the carotids, it can actually have a major neurological deficit as well, and spinal cord injury, and this again is more common in the type A. And then some of the other consequences, particularly the development of renal failure, which, as we know, is actually one of the indications in patients with type B dissection that there is a lack of perfusion of the renal arteries, and this may be actually an indication to perform early intervention in these patients. And of course, as well, the development of lower limb ischemia. So that's from a clinical presentation. Now, for laboratory testing in suspected aortic dissection, the guidelines put here a set of different laboratory tests. I would just like to highlight those. Many of these are just routine that we do most of the time in the patients who present with chest pain. But here, one word on the D-dimers. The D-dimers, according with these guidelines, they should always be considered along with the pre-test clinical probability, which, as I will show you also in a minute, we have now some sort of a scoring system that we can use also to detect if the patient has a higher clinical probability or not. They are immediately very high in acute aortic dissection, but they may be negative in intermural hematoma and in patients with ulcer. Now, some of the other tests, of course, can also be relevant, but this is the concept that the guidelines underline. Now, in terms of clinical probability, there is this score, which is the clinical probability score of an acute aortic syndrome. The risk score is from 0 to 3, according to the number of positive categories. And for each one, if there is any evidence of each one of these different columns, it's 1 point per column. So the patient may go from 0 to 3. And the highest, of course, the higher the probability of having an acute aortic syndrome. There are the so-called high-risk conditions, like if the patient has Marfan syndrome, of course, if there is a family history of aortic disease or known aortic valve disease, known thoracic aortic aneurysm, or previous aortic manipulation by surgery or by intervention. These are the high-risk conditions. There are high-risk pain features from a clinical standpoint. If it's an abrupt onset, if it's very intense, if it's ripping or tearing. And then the high-risk examination features like the evidence of perfusion deficit, or the presence of a diastolic, aortic diastolic murmur, or hypertension or shock. So any one of these columns present, 1 point, 0 to 3 points, the highest, of course, the higher the probability. Now, from a diagnostic standpoint, as I mentioned, this is one of the challenging areas, and here the role of imaging is central. And all types of imaging can be used. I will show you what the algorithm says, but basically all kinds of imaging can provide information that can help us to make the diagnosis. They can provide information that can be related in aortic dissection with the visualization of the flap or the extension of the dissection, the involvement of different structures, if there is aortic regurgitation or not, if there is pericardial effusion or not. So there's a whole lot of information that can help us to guide from a diagnostic standpoint the diagnosis of each one of these conditions, and the same thing for the other conditions. I would like here to, what happened here? To show one example by using echocardiography, which is at the center of the diagnosis of this patient. And as I will show you, the transthoracic echo is, let's say, the first imaging technique that should be used in these patients. And then, if needed, the use of transesophageal echo or CT or MRI, as I will also show you. And this is a typical example of a patient with an aortic dissection type A. You can see a dilated aortic root. The ascending aorta dilated, and you can see nicely here a flap. You see here the leaflets, the aortic leaflets, and the nice flap here, which in the transesophageal echo, it can be clearly shown. Here we have a transesophageal image with here the aortic valve cusps, and here just above the cusps, you can see nicely the flap, and then with color also demonstrates the presence of concomitant aortic regurgitation. Again, by shifting a little bit the cusps, and that's the mechanism why these patients develop aortic regurgitation. And you can even see a tear here in the proximal part of the flap, which is something that can also be useful from the strategic standpoint. Now, if we compare the different techniques, the different imaging techniques, you can see here that all of them, they have advantages and disadvantages, or they can provide more information in certain aspects related to the disease, and others may be complementary. And that's the reason why, for the workup, usually more than one technique is needed to be used to make sure the diagnosis is the correct one. Not only to diagnose, but also to detect the extension of the disease. And this is where the techniques that have a better spatial resolution, like MRI or CT, should be used also in these patients. But in many patients, and we use routinely thoracic and transesophageal echo, in many patients we can actually have the diagnosis with these techniques. But then what is important also is that there are some measurements that have to be done, like measuring the different diameters of the aorta, and particularly for the follow-up of these patients, it's very important that the same technique should be used. So the comparison can be done by using the same technique. And what is also recommended in the guidelines is that if there is a need for continuous repetition of the exams, we should use a technique that should be less iatrogenic to the patient, meaning in terms of radiation. So probably the use of a transesophageal echo or MRI, particularly in patients that we know are going to need more studies over the following years, probably is more indicated than the CT, which may be very useful in the acute setting, but probably not so useful in the follow-up of these patients. So here we have the algorithm in the decision-making in patients who have a suspected aortic dissection. And we can see that the first question is the patient stable or unstable. Of course, if it's unstable, then immediately do a transesophageal echo, transthoracic transesophageal echo or CT. In our case, we always do a transesophageal echo, and if it is confirmed, then this patient should be treated accordingly. If the patient is stable, then let's look at the score. Is it a low probability or a high probability score? If it is a high probability score based on the clinical conditions, then the patient should do a transthoracic echo. If the transthoracic echo shows that there is a clear type A dissection, then this patient should be immediately sent to the surgical team for operation, and probably in this case the use of a transesophageal echo can be done actually even in the OR when the patient is being prepared for the intervention. If it's inconclusive, the transthoracic echo, then here there is a role for the other imaging techniques, and again the use of CT can be useful, but also transesophageal echo or MRI. If it's a low probability, that's where the use of D-dimers can be also useful, as I've shown you before. And again, by using some combination of these different aspects, and by using also the different imaging modalities. And here, it's also important to state that it depends a little bit on the local circumstances and on the local experience, then it's confirmed or not the presence of an acute aortic syndrome, and therefore, by using this algorithm, you narrow the chances of missing a patient with an acute aortic syndrome. So here we can see that according with the guidelines, all these patients should undergo this pretest probability. In terms of the D-dimers, we can see that they are a two-way indication, so they should be considered particularly because they can be helpful to rule out the diagnosis when they are negative, and particularly in the setting of acute aortic dissection. If it's an intramural hematoma, we have to be careful because they may still be negative at that time. In terms of imaging, transthoracic echo is a 1C indication. In unstable patients, again, the use of transesophageal echo or CT. In stable patients, then follow the different imaging modalities, and these are all one indication for these patients in this setting. And in case of initially negative imaging with persistence of suspicion of an acute aortic syndrome, then the imaging modality should be repeated, and it's recommended that these are the patients where you don't have for sure the evidence of any dissection or any acute aortic syndrome, but you still suspect, and you keep the patient a few hours and repeat the imaging modality, and again it's the 1C indication. In terms of treatment, it's very important to understand that untreated, these patients with acute aortic dissection, they have a 50% mortality rate within 48 hours and 90% at 1 month. So it's an emergency that once identified, these patients go into treatment. The treatment now, the recommendation is that the use of thoracic endovascular aortic repair is now considered the treatment of choice unless it's not technically possible or for some reason it's not available. But the current recommendation based on the different studies, and this is one of the studies, the INSTET trial, which demonstrated that there were better results when using the thoracic endovascular treatment on top of optimal medical treatment, and this is currently the recommendation for the treatment of these patients. Of course, on top of all the other medical indications, medical treatment that these patients need to undergo, like pain relief and so on. But now it's a recommendation, and 1C recommendation, that even in complicated type B aortic dissection, the use of TVAR, meaning thoracic endovascular aortic repair, should be done. And if there is a contained rupture in a thoracic aortic aneurysm, it's also considered as a 1C indication, the use of the endovascular treatment. So this basically summarizes the different indications for the intramural hematoma, penetrating aortic ulcer, or traumatic aortic injury is a two-way indication, which means that it should be taken into account as a treatment strategy for these patients with acute aortic syndrome. Now, just a word in terms of follow-up. As I mentioned, it's very important that once the patient is treated and it's properly followed up, because we know that there are potentially many types of complications or abnormalities that can follow the treatment of these patients, both treated surgically or by the endovascular strategies. So it's important that they should be done properly, and they should be done also with the same imaging modality. The recommendation is that after the TVAR or surgical aortic repair, the first follow-up should be performed at 1 month to exclude any early complications. And then, of course, the follow-up should include risk factors control. Blood pressure should be monitored closely, because we know that more than 50% of these cases may actually have some sort of resistant hypertension. And then I will finish in 2 minutes. I need 2 more minutes. And also, if after TFAR, or can I just have 2 more minutes? If the patient is stable and there is no evidence of endoleak after 2 years of surgery, then the recommendation is that it's probably safe to extend the imaging intervals for 2 years. But of course, these patients need to be followed up clinically, and if there is any suspicion of any complication or any problem, these patients should then be properly imaged. Just a word on intramural hematoma, just to say that from a diagnostic standpoint, it's basically using the same strategy as for aortic dissection, and also in terms of treatment is the same sort of indication. So if there's intramural hematoma, if it's a type A, these patients have indication for emergent or urgent surgery, and because the mortality is basically very similar to the one with the aortic dissection. And these are just some of the particulars of complications related with intramural hematoma. And in terms of management, as I've mentioned, it's a 1C indication that all these patients should have urgent surgery if there is a type A intramural hematoma. For the penetrating aortic ulcer, the recommendation is that in the case of a type A, surgery should be considered, so the 2A indication, and again here, the use of TEVR should be considered in the treatment of these patients, particularly complicated, both type A and type B. So, in terms of acute thoracic aortic syndrome, I think we can conclude that these are potentially deadly conditions. The use of imaging is very important for the establishment of diagnosis and then of treatment strategy, and that surgery is recommended in all type A. In type B, it's very high now, the indication for doing endovascular treatment, particularly if some complications are developed. All this is in the guidelines that are available on the website of the society. There are pocket guidelines, and I know that our society is doing a lot of work to disseminate these guidelines. But today we have all this information also in apps, so you can actually upload the information and have it at the bedside of your patient in the clinics. And this is certainly one area where we can improve the way we can disseminate these guidelines. And can I have the final slide? It's just,
1 minute.
was just to show a little bit of publicity call conference in London, where I'm sure many of these things will continue to be discussed. So thank you very much.
Thank you for this wonderful. I know that it's a very difficult task to make it in 20 minutes, but let's summarize because of the audience here for the aortic dissection depending on clinical suspicions. It's very, very important because sometimes you didn't find anything except the pain, and then you decide if this is aortic dissection. My question is, how much the percentage of triple rollout sign in the aortic dissection? I mean, if the 3 acute infarction, pulmonary embolism, aortic dissection. If you have pains, you treat patient with pain without ECG changes, unsuspicious. Do you have any study showing that I know that it's diagnosed by CT, but any study by CT or even clinical and CT showing how the percentage of aortic dissection
in patients who present
with pain with normal ECG, severe pain with normal ECG?
Well, the majority of, and that's actually one of the problems, the majority of patients with acute aortic dissection or acute aortic syndrome that does not involve the ostium of the coronary, they usually have mild abnormalities on the ECG or can even be normal. So actually it's one of the things that we always teach our fellows is a normal ECG does not mean that the patient does not have an acute aortic syndrome. So I would say that the large majority, they have either non-specific STT changes or basically normal. They may have, of course, because many of these patients are hypertensive, so they may have some signs of left ventricular hypertrophy on the ECG, but signs of other abnormalities are not so common. But again here, as you said correctly, is the clinical suspicion, and also, and that's why in some centers they develop this chest pain clinic, so you can actually follow up these patients, because of course the characteristics of the pain, as we know, although the classical one is a very sharp pain, abrupt, acute, that can go to disseminate to the neck, to the back of the neck, and so on. But this we don't see now every single patient with acute aortic syndrome. So the clinical presentation here should be triggered, sort of an alert that then we should follow the procedures, in terms, particularly the use of imaging, to rule out any evidence. And still, we still sometimes miss a few particular ones who start with very small, localized dissection.
Thank you, Dr. Pinto, for your lecture. Actually, I am one of the very few cardiologists doing TIVAR in Egypt. And I want to know what's the situation in Europe. I mean, who's performing TIVAR? Is it the cardiologist, the vascular surgeons, the cardiac surgeons? What's the situation?
Well, it varies. There are many centers that are the cardiologists doing. I can tell in my center, we do it together with the vascular surgeons, and we've started the program, but the vascular surgeons have the lead, we have to say. So, but that's because of local circumstances that our vascular surgical team has always been very aggressive, let's say, in some of the introduction of new modalities. So they actually introduced the TEVRs in our hospital, but we work very closely because, of course, what happens is that we make the diagnosis and then it's either surgery or TEVR, and we work with both teams. Actually, we have some sort of a department that involves both cardiology and cardiac surgery and the vascular surgery. But I know that in other centers, the cardiologists are doing it. So I think, again, the point here is this should be also a good example of a heart team or a heart and vessels team, if you will. And what really matters is that you have the different specialties involved. The one who does it, of course, needs to have the training and the expertise to do it, but also have the facilities that if there is any problem, any complication, that is available readily, and any sort of intervention needed by the right team.
So essentially it's a teamwork, it's not just one specialty.
Again, it varies a little bit. In our case, who performs the TEVR are the vascular surgeons, but I know cases in Europe of some hospitals where are actually the cardiologists doing it. So it varies depending on the local, let's say, organization or local logistics.
Yes, in our center in Alexandria, Adil is doing the same thing. We are combining with the vascular surgeon. Yeah. Vascular surgeon, if the patient is belonging to the vascular surgeon, actually the vascular surgeon is doing alone. But if belonging to us, usually we do it with the vascular surgeon just to open the artery. My question is, there is no doubt about TIVAR for the distal dissection, but for the ascending dissection, usually need to know the coronary anatomy in order to have the surgery. Sometimes it's difficult to do a CT coronary angiogram or even to do coronary angiogram. I have a lot of patients with this. I'm suspicious, and sometimes do an echo, or sometimes the echo is not evident and you don't do CT and don't try and do coronary angiogram, you fail, and you just do an aortogram and see the dissection. And back to the CT, you don't have time to do the coronary, so the patient go direct to the OR. It happens in your center that you do coronary implantation without knowing the coronary anatomy?
No, you should know the coronary anatomy. And actually, either CT or we use more transesophageal echo. You can actually have, I would say, 99% of the cases, you can actually see the ostium of the coronaries. And not only the ostium, but also the distance from the valvular plane and the annual plane. So I agree with you. You know, it's essential that you know also, because if you do a surgical procedure, or the classical procedure of you may have to resuspend to reimplant the coronaries. And for that, it's important that you have a good idea of the location. Also, if there is involvement or not, because they may actually implicate in terms of the procedure that will be done. So I think it's important that you know, in this kind where it involves the ascending aorta, if there is involvement or not of the coronary artery and where it is located.
Any questions from the audience?
Just thank you, Fausto, for this presentation. Just one comment, and I would like to have your opinion. Regarding imaging, echocardiography, sometimes we don't see the flap. However, in the presence of moderate aortic regurgitation with a structurally normal aortic valve, one should always raise this question of dissection and push further for TE. We face situations where you see moderate aortic regurgitation with a completely normal structurally aortic valve. So we should, you agree with this, we should push for a TE or a CT scan, because this most of the time can hide or cover a dissection, aortic dissection.
Yeah, no, I completely agree. And actually, as we know, the sensitivity and specificity of the transthoracic echo is much lower. So, and it happens, I'm sure we all have these patients whereby transthoracic echo, we may suspect, like AR or a little bit dilated aortic root, and you may have some fuzzy image that you may suspect, but still not be for sure, and then the use of transesophageal echo should be done. Actually, I used to say that my threshold to do transesophageal echo with these patients is very low. It's like in endocarditis, you know. It's if you have a suspicion, do it. You know, don't think twice. Or a CT, of course, but if you can do it, the advantage of the transesophageal echo is that you can bring it to the patient, and you can do it almost immediately. You don't have to move the patient into the radiology or whatever the CT scanner is. So I think that's one of the big advantages of the echo. And my threshold is very low. So if I have any suspicion, I immediately do the transesophageal echo.
Okay, thanks, Fausto. Thanks very much.